So thanks, James, and thank you very much to the organisers for the opportunity to present our research at this incredible symposium. The Neurizon, the name reflects our commitment to advancing neural research and our mission to be a leader in the development of new treatments for neurodegenerative diseases. Just the disclaimer slide. I'll be talking about some forward-looking statements in this presentation. So Neurizon is developing product candidates for neurodegenerative diseases, and the drug that we're using is a drug called Monepantel. And Monepantel is a drug that has a long history as a veterinary product. It's used as a product to treat roundworms in sheep. It's only been recently that it's been rediscovered as a drug that can inhibit mTOR. mTOR pathway is a very important pathway within all cells that controls energy, the immune system. It's an important pathway in oncology as well. Where our lead product is in ALS, motor neuron disease, as we know it here in Australia. We have a strong IP position around the use of the product in neurodegenerative diseases. As I mentioned, our lead product is in amyotrophic lateral sclerosis. We've recently completed a phase 1 study, and we've also been recently selected as a participant, one of the regimens in the Healey ALS platform trial. And we hope that this being selected in the Healey ALS platform trial will allow us to go on and potentially use this study as a way of receiving accelerated approval from the FDA. A little bit about the drug, Monepantel. It is, as I mentioned, a veterinary drug. It's been approved in a number of different countries, 36 countries around the world, including Australia and New Zealand. It's used to remove roundworms or to treat roundworm infestations in sheep. The pharmacology that it uses to treat nematodes in sheep is completely different to the pharmacology that we're using to exploit in ALS. In the pharmacology that it uses to remove nematodes is via the N-acetylcholine receptor. And the N-acetylcholine receptor is specific for the nematode. You don't find that type of receptor in mammalians. In humans, it's used as an mTOR inhibitor. And we use the S enantiomer of Monepantel for all our studies. As I mentioned, Monepantel, it's an mTOR inhibitor. We also use or name Monepantel as NUZ001. And as an mTOR inhibitor, it has been shown to inhibit and reduce the protein production and increase the recycling of existing excessive and microprocessed cellular proteins. In ALS, we're looking to inhibit mTOR as a way of inducing autophagy. And autophagy is that natural process that all cells use to remove dysfunctional proteins, misfolded proteins. And in ALS, we're hoping to use the process of autophagy as a way of removing, clearing the toxic buildup of aggregates, in particular TDP-43. So the pharmacology studies behind deducing the mechanism of NUZ001 was largely done in oncology cells. That's how the original discovery around the benefit of using Monepantel was originally discovered. And here we can see on this slide how the treatment of ovarian tumor cells and also glioma cells induces the formation of autophaga lysosomes, which is the hallmark lysosome or sac for autophagy. We see an increase in the formation of those lysosomal sacs as treatment goes on. And in this particular slide, you can see that there's a 20-fold increase in the formation of those sacs at 72 hours in U87MG cells, and over 100-fold increase in the ovarian cancer cells A2780 after 72 hours. If you take a look at the molecular level, you see that NUZ001 impacts the phosphorylation status of autophagy-associated proteins. The experiments that were conducted were again in cancer cells, ovarian cancer cells, and those experiments showed that we're able to decrease the amount of raptor phosphorylation, which is critical to the formation with mTOR to allow its substrates to dock into mTOR. So we've been able to show that downstream, we then affect the phosphorylation status due to that separation of raptor from the mTOR complex. And this is new data that I'd like to share with everyone today. And it's quite topical given the first presentation that we had today around TDP43 aggregation. So these results are only come available this week. And it was done in collaboration with Ncardia. And as you can see from this slide, we looked at the ability of NUZ001 and also its major active metabolite NUZ001 sulfone at its ability to reduce the aggregation of TDP43 in response to a stressor. And the stressor on this occasion was a proteasome stressor MG132. And as you can see on this slide, after co-incubation of TDP43 M337V motor neurons with astrocytes, we see an aggregation following stimulation with MG132. We see a stimulation, we see an aggregation of TDP43. When you look at the effect of the compounds NUZ001 and NUZ001 sulfone, you see a nice dose response at reducing the reduction or reducing TDP43 aggregation. And at a concentration of 0.0625 micromolar, you're seeing a 50% reduction in the aggregation of TDP43. These levels, these concentrations, are consistent with the concentrations that we're seeing when we deliver the drug clinically. And in another set of studies that were conducted by Ncardia, looking at a mutated TDP43 phenotype in motor neurons, in the M337V motor neurons, they used the microelectrode assay to look at electrical conductivity compared to wild-type motor neurons. And as you can see from this slide, treating with NUZ001 and NUZ001 sulfone, the major active metabolite, you're seeing a rescuing of the phenotype back to the wild-type phenotype, both in the number of bursts, the interburst interval, and also the number of network bursts. So these encouraging results came after we completed our phase 1 study, and our phase 1 men study was conducted in Australia and completed earlier this year. And this study was conducted in a patient population that consisted of 11 men and 1 woman. They had familiar and sporadic ALS, and they had to have their first symptoms occur with less than 3 years prior to screening. The median age of the patient population was 63.5 years, and this particular study was a dose escalating study. So we looked at 4 different doses, 2, 4, 6, and 10 milligrams per kilogram. And the way that the study was set up was that we enrolled 2 cohorts. Each cohort contained 6 patients. The first cohort received 2 and 6 milligrams per kilogram, and the second cohort received 4 and 10 milligrams per kilogram. There was 2 centres in Australia. One was led by Professor Susan Mathers, and the other one by Professor Dominic Rowe. And what we looked at, given that this was a phase 1 study, was primarily safety of the drug over an extended period of time. We also looked at the pharmacokinetics of the drug and its major metabolite, both in the plasma and CSF. And we also looked for preliminary signs of efficacy using the ALS-FRS revised scale, also quality of life, cognitive function, and slow vital capacity. We also looked at some preliminary biomarkers in neurofilament light chain, both in the serum and also CSF, and also P75 levels. In terms of the demographics, the baseline characteristics of these patients, as I mentioned, the median age was 63.5. The most common site for first disease onset was the upper limb region. Most patients were considered probable in their ALS diagnosis, and the median treatment duration was 32.4 weeks for dose level 1, so that was 2 milligrams per kilogram, 22.6 for dose level 2, 4 milligrams per kilogram, 16.7 weeks for dose level 3, or 6 milligrams per kilogram, and 8.1 weeks, so a short period on the high dose at 10 milligrams per kilogram. And this is an overall schematic of how the study functioned. So first cohort of patients, they were on 2 milligrams per kilogram. When that dose was deemed safe by a safety monitoring committee, a next cohort began enrollment of 6 patients. They were placed on 4 milligrams per kilogram until that was deemed, or when it was deemed safe by a safety monitoring committee. The first dose level of 2 milligrams per kilogram went on to 6 milligrams per kilogram. That dosing schedule between cohort 1 and cohort 2 went for a total of 12 months. Those patients then were able to stay on drug at 6 milligrams per kilogram through a compassionate use program for 3 to 5 months. And 10 of the 12 has since rolled over into an open label extension study at the top dose of 10 milligrams per kilogram. In terms of safety and tolerability, which was the primary aim of this study, there was no deaths, there was no serious adverse events related to treatment, and a very low incidence of adverse events. In fact, only 3 that were possibly related to treatment. One was a mild case of raised liver enzymes. There was another of increased hair growth, and then there was 1 episode of constipation. So a very, very benign safety profile for this drug. There was 1 serious adverse event, but that was unrelated or deemed unrelated to treatment. In terms of looking at preliminary efficacy and using the ALS-FRS score, what we did, given that it was an open label study, we teamed up with Berry Consultants and compared our 12 patients back to the PROACT database. And these are the results shown on the slide. And what we found was all 12 patients, so not discriminating between dose, we found that by comparing them to the matched controls in the PROACT database, we saw a 39% slowing in the rate of decline in our patients compared back to their matched controls. The difference was close to 0.5 points per month, and that was approaching statistical significance. When we then take a closer look at what we're calling cohort 1 and cohort 2, so cohort 1 is the patients that were on the lower doses of 2 to 6 milligrams per kilogram, and cohort 2, the higher doses of 4 to 10 milligrams per kilogram, you can start to see that there is some evidence of a dose response. So cohort 1, we saw a 23% slowing in the decline compared to their matched controls in the PROACT database. In cohort 2, we saw a 58% slowing in the rate of decline compared back to their matched controls in the PROACT database. The exploratory endpoints that we looked at, we saw really only a minor decrease over the treatment period from pre-dose in a quality of life questionnaire. We saw no decrease, in fact, a 2% increase in cognitive function over the treatment period, and a small decrease of about 11% in slow vital capacity in these patients. One of the exciting results that came out of the phase 1 study in the patients that consented to providing cerebral spinal fluid was a marked decrease in NFL levels. And that marked decrease was correlated to the dose levels that they were on. So we saw a greater decline in NFL levels in cohort 2 on the higher dose compared to the patient that was on the lower doses in cohort 1. Interestingly, even though we saw a marked decrease in NFL levels in CSF, we didn't quite see that in neurofilament light chain in serum. In fact, the level remained quite stabilized during the treatment period. We did see potentially something in urinary P75 in cohort 1. Generally with P75, as the disease progresses, you see an increase in P75 level. We saw a stabilization in cohort 2, suggesting potentially some effect on that biomarker. So in summary, for the phase 1 study, we achieved the primary objective, which was excellent safety and tolerability. We also showed that there was some evidence of preliminary efficacy, particularly when you compare back to the PROACT database. Importantly, we were able to show that the study drug and NUZAD001 and its active metabolite both cross the blood-brain barrier into the cerebral spinal fluid. Survival, and I'll talk a little bit more about survival in a minute, but we didn't see any deaths over the 12-month period in these patients. And we believe that we've settled on an optimal dose for our regimen in the Healy platform trial. So quite recently, mentioned before that the 12 patients in the phase 1 study went on to compassionate use for a period of 3 to 5 months, and 10 of those patients have since enrolled, are currently in our open label extension study receiving drug at 10 milligrams per kilogram. And this is a recent analysis that was done by Berry Consultants looking at overall survival probability. And this was done about a month ago. So some patients had been on drug continuously for for up to 23 months. In fact, at the moment, we have a number of patients that have been on drug for over 25 months. And as you can see from the Kaplan-Meier curves that were constructed by Berry consultants, and those Kaplan-Meier curves, our patients were compared back to the PROACT database. You can see that treatment with NUZ001 significantly prolongs the survival of patients compared to their matched controls from the PROACT database, and that was highly statistically significant. If you look at the hazard ratio, it indicates that the treatment with NUZ001 reduces the risk of death by 80.3%. And again, that was statistically significant with a p-value of 0.0059. So I'll conclude there, and we'd like to thank the patients that were involved and are still involved in our phase 1 study that's since gone on to open label extension study, their caregivers and their family members. And we look forward to moving forward next year with our regimen in the Healy platform trial. We'll take any questions.
Thanks so much, Michael. We do have a few questions that came into the chat, so I'll just sort of read them out. So the first one I think just has to do with this sort of central role of mTOR, and just asks, are you not concerned with the reduction of synthesis of essential proteins?
We haven't. Yeah, I mean, that was one of the the great things that came out of the phase 1 study was that and still coming out of the data that we're collecting from the patients in the open label extension study is that the very low adverse events that we're seeing that are contributed to the study drug. So at this point, there's no reason to believe that we're altering protein expression in any kind of deleterious fashion.
Yeah, okay, that's great. So there's also a question about the fact that autophagy is ATP dependent and ALS neurons are ATP deficient. So do you think that has an impact on the action of the drug?
It's a great question. That's something that we're doing quite a bit of work at the moment, if you like, filling in some of the gaps, as you would have seen from the presentation, where we kind of had the hypothesis that because we're inhibiting mTOR, there is a potential path for us to remove the toxic buildup of proteins, in particular TDP-43, through autophagy. We're only just starting to dive deeper into not only the mechanism of action and how it relates to ALS in neurons, but also looking at whether is it in something in addition to mTOR that we're potentially having an effect on. So we've got a number of preclinical studies going on at the moment, all aimed at deducing and trying to gain greater insight into exactly what mechanisms are at play with Monepantel, perhaps something in addition to mTOR inhibition and autophagy.
And then we'll end on this. I think there's a few comments that are just urging caution and looking at clinical outcomes in a phase 1 trial, efficacy outcomes. And I just wanted to give you 1 second to maybe just give your thoughts.
Yeah, definitely. I mean, there's this result obviously has to be confirmed in a much larger study. I mean, that's generally drug development 101. You start with a small patient population, you assert safety and tolerability, identify the dose that's best to go forward with. I guess we're somewhat a little bit different to your traditional drug development paradigms with dealing with a rare disease like ALS. We have some would say the luxury of using comparisons to natural history database, and I think Berry consultants, with their use of the PROACT database and how it's accepted by the FDA for running simulations it certainly makes up a big part of the Healy platform trial, that I think we can get some comfort that we can use it as a guide. It's certainly not, we can't say 100% and be completely confident that the results that you get when you compare back to the PROACT database are the results that you're going to get in a larger phase clinical study, but it certainly gives you confidence. It certainly gives you direction around assessing a number of the different variables that are important to designing a robust clinical study in order to potentially ensure success. So certainly understand where the question is coming from.
And thank you very much. That's great. And just to clarify, the Healy platform trial it does not use PROACT in the primary analyses of the RCTs, but there are ways for modeling that we use that. So yeah, no, very nicely done. Thank you very much for showing us that program. Again, like all the programs today, we're really excited about where this is going to go.